We often have the notion that simply because you have a germline mutation that you must get a mastectomy. And there's been more of a movement to suggest that breast conservation may be acceptable in these patients.
I think it needs to be really a shared decision making, and we need to stress that in such a patient, overall survival is not changing. We need to be careful, not putting too much pressure on patients to undergo these prophylactic procedures. And I very much support what he had said. Whenever possible and reasonable, I try to differentiate between the cancer surgery and the prophylactic surgery, because that's a completely different conversation.
Right. So what I decided to do, because it's late in the day after a long meeting, and what I elected to do is just present two very simple cases that hopefully illustrate some of the key issues that we have to take into account as a multidisciplinary team taking care of patients with early stage breast cancer. So there's not a lot of slides, just a couple of cases, and we're going to try and generate some discussion that'll hopefully highlight the necessity of good communication and a concerted plan to interact in order to best serve the patient. So the first case is that of a 35-year-old premenopausal female who self-detected a left breast mass. She had no prior mammograms up to that point. She was completely asymptomatic and had no other medical history. She's been pregnant twice, delivered 2 children. Both her mother and maternal grandmother had postmenopausal breast cancer, and both are living. On mammogram, she had approximately 3-centimeter left upper quadrant mass, and there was some suggestion, although clearly not definitive, that an axillary node might be slightly enlarged. On her physical exam, she had a freely movable left breast mass, and there was indeed a suspicious axillary node that could be palpable that was approximating about 1 centimeter. She underwent a biopsy that confirmed infiltrating duct carcinoma. It was ER0, PR0, HER2 had a nuclear grade of 3, and the Ki-67 or proliferative index was 30%, so triple negative breast cancer. She underwent staging scans, including a CT and bone scan that showed no evidence of distant disease, and she did undergo germline testing, which confirmed a BRCA1 mutation. So what I'd like to do now is just consider some of the things that we might talk about as colleagues when we encounter such a patient. And I'm going to highlight a number of different things on the next slide that will sort of go through that I hope illustrate the need to talk to one another in order to deliver the best care. So I'll turn to Professor Rubio and Audisio really with the first issue about surgery, and that is just how do we assess the nodes? Are you satisfied the biopsy was positive? We'll talk about neoadjuvant therapy. Is it necessary to clip the nodes? And I should also include, obviously, Dr. Kim as well, and anybody else who wants to come, and Dr. Gnant, Professor Gnant on local therapy issues. But first is, do we clip the nodes? And do we need to do anything else before we make decisions about systemic therapy?
So first thing, before deciding on clipping the nodes, I think we need to do an MRI on the patient. She's a young patient, probably dense breast, and considering that she probably goes to neoadjuvant treatment, we would like to see the response. Then in my institution, we clip one node because there is no data that you need to clip more nodes, and it seems that there is only one node that is positive or looks like positive, or the biopsy is positive. But there are other groups that just do the sentinel node and they don't clip the nodes. And we have enough data that supports that you can do both if you have already your expertise and know your false negatives. So I will clip, but other people won't.
And how do you clip?
We usually put a marker that is visible under ultrasound because we do intraoperative ultrasound, but there are many ways. You can use magnetic sheets, radioactive sheets. I mean, there are plenty
There are
of...
so many devices. I wondered wondered whether you have any preference, magnetic, whatever. Doesn't matter.
Intraoperative ultrasound is the most cost effective.
Any other thoughts on the issue of initial assessment of the axilla from other members?
No, because we know that if it's a CN1, it's fine. You know, we don't care if it's 1 or 2 or 3 positive nodes in the axillary ultrasound.
All right. So, in most situations in this circumstance where we have a positive node and certainly a tumor that's at the 2-centimeter margin and above, at least in many parts of the world, the approach would be to give neoadjuvant therapy and include immunotherapy as a component of that per the Keynote 522 trial. So I'll ask 2 questions. Maybe Dr. Rugo can start us out. Obviously, this is an approach that we have available in most countries, but not all. So would this be your standard? And in the absence of a checkpoint inhibitor, would there be an alternative approach that you would view as equally effective?
Well, in some ways, she has an advantage of having a BRCA1 germline mutation because these tumors are more chemotherapy sensitive. And overall, we saw higher PCRs, for example, in the Brightness trial, even in patients who had not received platinum. Interestingly, they just had a better PCR rate, and that's been seen. We would give immunotherapy always. This is a T2N1 tumor in a very young woman. We would get an MRI before starting because she has a BRCA1 mutation. We get it generally in young women anyway, but in this case in particular, you want to know if there's other lesions, for example, contralateral disease, et cetera, that you're not seeing, so that you can follow it and understand what to do after surgery. So we would start with a Keynote 522 regimen, if not on a clinical trial. And if you don't have an PD-L1 or PD-1 inhibitor available, basically I'd use the backbone for Keynote 522 without the pembrolizumab. There is data that a PARP inhibitor as neoadjuvant therapy for patients with BRCA1 in particular mutations can give a PCR rate 60% or higher. But in general, we don't have approval for using PARP inhibitors in that setting. And in countries that don't have access to pembrolizumab, they're certainly not going to have access to a PARP inhibitor in this setting.
So let me ask a question. If I altered this just somewhat, and instead of 35, instead of the woman having 2 pregnancies and 2 children, she's 30 years old and never been pregnant. How does that change your thought? Are there ways or things that you would employ to spare the ovaries so that she potentially could get pregnant in the future?
I've had 35-year-olds with 2 children harvest eggs because they
Right.
planned a 3rd child. So we always ask that question and really push forward. We have partners who will see the patients right away and do egg harvesting so we can freeze the eggs or embryos if they have a long-term partner. And then we use GnRH agonists during the chemotherapy. And for this patient who doesn't need, she may, who knows when she's going to take her ovaries out. Generally, the age keeps moving up. So we would, potentially use GnRH agonist, even if she completed childbearing to, shorten, I guess, to try and give her ovarian function for as long as possible before she has oophorectomies prophylactically.
Professor Kim, any other thoughts or anything different you would do? Anything different on the other end?
I'm okay. You want to?
I also agree with her opinion. Even though she has 2 children, we do not want to early menopause for this young lady. Even though she has BRCA mutation, probably she will receive prophylactic oophorectomy in the recent future. However, I think adding ovarian function suppression concurrent with chemotherapy will be beneficial for preserve ovarian function, I think.
Okay. So let's assume then this patient did proceed with Keynote 522. She had every measure taken to protect her ovaries. She had fertility counseling, et cetera. And she undergoes surgery and is found not to have a PCR, but she has an RCB score with some minimal disease, maybe an RCB score of 1, some minuscule disease in the breast and the node. So when we think about the post-op approach, again, this is dictated perhaps by resources, but the Keynote study would suggest you continue the checkpoint inhibitor. Are there circumstances where you would add to it in this? the PARP inhibitor, capecitabine, both?
Well, you know, I mean, the keynote data is there. However, in my clinical practice, it pretty much depends on tolerability during the neoadjuvant phase. So if we would tolerability. So if she has had severe side effects, we might have skipped the IO afterwards if she has a near total PCR, for example. PARP inhibitor, if not given neoadjuvantly, she would probably receive based on the Olympia trial. And well, no good reason to deny capecitabine, but patients have a tendency to be exhausted at some point. I think that's what we need to admit.
We would generally continue the pembro unless there was a reason to discontinue serious immunotoxicity, and give the PARP inhibitor and skip the capecitabine. That would be our approach.
So let's step back a moment, and I can put this back to Professor Rubio and Professor Audisio. If this patient, clinically did extraordinarily well with the neoadjuvant therapy, would your approach to the axilla be any different? Could you think of not doing it in this circumstance, any surgery whatsoever on the axilla?
So let me just go back a little bit. And I think it's important in terms of the surgical approach to put a clip on the breast. Even if you think the patient is going to have a mastectomy, you need to put a clip, because if the patient has a complete pathologic response, for the pathologist, it will be very, very difficult to find the area in a breast. So it's always good to clip the tumor in the breast, even if the patient is having a mastectomy. On the other hand, if she has a complete response in the axilla, we will do a TAT procedure with a clip, or we will do a sentinel lymph node biopsy. But as far as now, with a clinically positive axilla before neoadjuvant treatment, there is no data not to do anything. But if she had a complete response, we will not do an axillary lymph node dissection.
Michael?
Well, I think we have to, and it's terrible that I find myself on the conservative side of an argument, because that's kind of new. But I think we see some surgical fashion over omission here. I mean, after all, a sentinel procedure takes 10 to 15 minutes, has minimal morbidity, even in the INSEMA trial, which these patients were not part of course. So I think checking that there is actual excellent response in the axilla is something that is worthwhile. So not doing any surgery, I think it's not a very good idea. Some of these trials are running, but let's stay away from being too fashionable in surgical terms.
So what did you recommend? More or less?
No, I would do a TAT, as Isabel said, but I would not omit a sentinel node procedure in such a patient.
Yeah, I mean, we always will do, not being the surgeon, but we always do a sentinel node. And I think the big question really comes up about, if the node is gone, how many more nodes do you need to take? That's the first question. And the second question is, she's young, she has bilateral mastectomies, she has 5 millimeters of residual disease, and now her node is negative, however many you took out. Are you going to do radiation anyway?
Clear answer, no. Second clear answer, I'm in a privileged situation. I use frozen section, so that means that I will always know whether the sentinel node is positive. I will never go back for a second surgery just to obtain more nodes. But I have turned in these cases that you're describing to something that the old British surgeons called the axillary sampling. I will take 4 or 5, because 1 out of 5 feels much better than 1 out of 1 for the post-op discussion in the MTD.
Riccardo, did you have a comment?
No, overall, I'm in line with that. I would go for, we marked the primary and we marked the nodes. We were lucky that these patients had an extraordinarily good response, which links, as we know, to a better outcome. And therefore, picking up the marked areas is worth doing. I'm content with a limited number of nodes. That is the one that has been marked. Okay, I might end up finding something nearby, but it's not my target, and I'm content with that.
Okay, go ahead.
Yeah, I'm not a radiation oncologist, so I'm not an expert on that. but this patient has all the features of a high-risk patient: age, subtype, not complete response, positive axilla. As far as now, even if we have the results of the 5-year follow-up of the study on radiation therapy, in my institution, we will irradiate her.
Let me ask Dr. Zhang and Dr. Professor Kim. You know, we often have the notion that simply because you have a germline mutation that you must get a mastectomy. And there's been more of a movement to suggest that breast conservation may be acceptable in these patients. I'm just curious what your personal approach is. Do you recommend that all patients like this need a mastectomy, or can you do breast conservation?
Thank you for your question. So compared to Western country, the rate of like prophylactic bilateral mastectomy in Asian country is much less than Western country. However, after the result of Matteo, he published that the BRCA young breast cancer patient, the bilateral mastectomy can increase. There are some survival difference for the young BRCA mutation patient who receive bilateral mastectomy. So especially these patients who anticipated at least 4 months of neoadjuvant chemotherapy, there are enough time to discuss about their treatment and the effect of survival probably benefit for young BRCA mutation patients. So even though it is not really relevant or not, but yeah, so nowadays the rate of bilateral mastectomy in South Korea is increasing. So before it was only 15% before, but nowadays, especially the patients who receive neoadjuvant chemotherapy, around 40% of patients receive bilateral mastectomy.
I'll come back to you in a second, Michael. Can we get Dr. Zhang's thoughts real quick?
Can I speak in Chinese? Because we have a professional translator. Okay.
Well, in this case, I would think after neoadjuvant chemotherapy, if I were to achieve PCR or near PCR, in my clinical practice, I would recommend, breast preservation. Breast conserving versus mastectomy. I don't think there's a much difference in terms of post-op recurrence. Even with those carrying BRCA mutation, they could consider preserving breasts.
I just wanted to support what you said, because it's not all Western countries. It's mainly the US. And we're putting a lot of pressure. No, I'm not saying the evil. I think it needs to be really a shared decision making, and we need to stress that in such a patient, overall survival is not changing. It's the healthy BRCA carrier who really benefits, not the breast cancer patient, because her recurrence will come from the cancer that's already there. So I think we need to be careful, not putting too much pressure on patients to undergo these prophylactic procedures. And I very much support what he has said. Whenever possible and reasonable, I try to differentiate between the cancer surgery and the prophylactic surgery, because that's a completely different conversation, a completely different emotional burden. And if everything needs to be done at once, I think we sometimes push patients into decisions that they might be remorseful later.
Isabel?
And I think
you have something?
no?
Oh, so I disagree. I think that in these patients, there is enough data that shows that the risk of contralateral breast cancer is 5 times higher than if it's an sporadic breast cancer. The risk of ipsilateral breast recurrence is higher than if it's not a mutation carrier. So I think that you need to talk to the patient clearly about the options. But the real options is that there is, not clear evidence that there is no survival benefit in triple negative BRCA mutation patients with breast cancer and bilateral mastectomies. I think there is data that there is a survival difference when they have prophylactic mastectomy. So you need to counsel the patient, but there are data that it's there that those patients are at higher risk of recurrence of contralateral breast cancer and probably of a better survival.
Last comment, Hope?
I think that, this is a 35-year-old woman with 2 kids who has a BRCA1 mutation. What we're doing now does not prevent the cancer in the contralateral breast. And what I see is that generally patients who've had full course treatment, first of all, they can't get an anthracycline again. And secondly, their bone marrow doesn't tolerate it well. Does she really want to get cancer for another triple negative breast cancer treatment for another triple negative breast cancer in 10 years? And I don't think we really have the survival data we need. We need survival data for 30 years for a 35-year-old or 40 years. So I think, and then if you have radiation and she does get another cancer, decides to do reconstruction, then her reconstruction won't be as good. So there is it's not a mandatory issue, but it's a very different issue for a patient who has a BRCA1 mutation and a triple negative breast cancer than somebody where you can at least provide some prophylaxis with anti-endocrine therapy. And having seen these patients with second cancers, they don't do well, and the cancers don't respond as well. So it makes me nervous for these women, despite the discussion here.
Okay, we're going to move on to the second case. My slides disappeared. So if we can go on. So the next case is that of a 50-year-old woman, perimenopausal woman who underwent annual mammograms and was found to have a suspicious right breast density that covered about 2.5 centimeters. Her prior mammograms in retrospect appeared all normal. She has no family history. She's completely asymptomatic and has no other medical issues. On physical exam, she does have a 2 to 3 centimeter right breast mass without any palpable lymph nodes, and the remainder of her physical exam is normal. She undergoes a biopsy, which shows HER2 3+ disease, both ER and PR positive, a high Ki67, nuclear grade 3, and she had germline testing, which was negative. So let's think about this from a multidisciplinary standpoint. We have somebody who has clinically node-negative disease, whose primary tumor is hovering around 2 centimeters, perhaps a little bit above that. So in this situation, it's often a walk down the hallway between the surgeons and the medical oncologist. Is there any circumstance where you would proceed with surgery as the first step uniformly?
No.
Professor Audisio, you have a comment?
Never.
This is a case that I am happy to discuss and offer primary endocrine. Although we don't have a vast amount of data, I think it's an option, and you can promptly monitor the progress, and within a month, you know whether the cancer is shrinking. And I've had very good results, and it's an opportunity that not everybody considers, but I think it's feasible.
So even in a patient that's also HER2 positive?
Yeah.
Okay.
We would not do that. And I think, we worked hard, even in the NCCN, actually, to say that, tumors T1C or greater, that neoadjuvant therapy could be considered, because you learn an enormous amount about treating in the neoadjuvant setting that you can then optimize her treatment in the post-neoadjuvant setting. So in this situation, we would actually get a mammoprint because we do put them on I-SPY. But, it's interesting. If you go back one, her HER2, you made her 3+?
3+.
So, it's interesting because in the FORGAIN-2 trial that was presented at ESMO Breast, again, this isn't definitive data, but it suggested that if you were HER2 3+, your PCR rates were quite high just with HP, trastuzumab, pertuzumab. So in this case, we probably would go with THP rather than a more extensive treatment, just over 2 centimeters. Patient has node-negative disease, and you can rescue out back.
Isabel.
If we follow the ESMO guidelines, patients HER2 positive with tumors bigger than 2 centimeters or 2 centimeters undergo neoadjuvant treatment. So we will send for neoadjuvant treatment. And I'm not going to go into the type of neoadjuvant treatment, but we were part of the study from Cortez, doing this PET scan and yes, again.
Michael.
I think the guidelines currently say 2 centimeters. In my institution, we would go down to 1 and maybe even a little bit below. So 7, 8 millimeter with high-risk features will have neoadjuvant treatment. Having said that, when we come to the type of neoadjuvant, I think the lower the risk, the higher chance for PCR, the less inclined we would be to go to something more intense or more dangerous. So as Hopper has cited, the smallish super overexpressors might even not, just dual blockade might be good enough. We'll have to see that, but probably because the next question you will ask is when do you use the ADC there? And I think, the larger the tumor, the higher the need for that additional 10 to 15% relative improvement in PCR, the more we would be inclined to do that.
Isabel?
So I think it's important because it's important to put this patient in the multidisciplinary because we need to know if there is any clinical trial available for this patient before deciding on anything else, type of treatments, on everything. We always see if there is any clinical trial.
All right. So this patient, the general consensus, not completely uniform, but the general consensus is this patient would get preoperative therapy with some form of treatment. Most people would get HER2-directed therapy, Riccardo, perhaps endocrine therapy. But if you gave preoperative HER2-directed therapy, what would be your recipe of choice?
When I was
And perhaps
Yeah.
comment, as Michael was alluding to, we now have several different options that we can use.
She's not, based on DB11, she wouldn't have been a candidate for DB11 treatment. I don't think any of us would give her that treatment for just over 2, and it's raining in here, but just an over 2 centimeter clinically node negative tumor, ER positive. I would use THP in that setting and not subject her to carboplatin, which can be tough, and we use paclitaxel rather than docetaxel. And I use cold gloves and booties, which means their fingernails don't fall off either. So I think it's actually very well tolerated. There's no risk of secondary cancers, cardiac risks, et cetera. And then you can rescue out back. I think the issue is what you rescue with is a question, because we're going to give endocrine therapy, and she doesn't really meet criteria for a DB05, but the U.S. approval made it so that you could give it to anybody. And the question is, would you really, if you had residual disease, would you really give 14 cycles of T-DXd?
Actually, I'm not a medical oncologist. Probably our medical oncologist will decide that. But usually we discuss about TCATP and also TATP also.
Okay.
And my question is, what do you recommend endocrine therapy for these patients after surgery?
Yeah.
Yeah.
我是一个外科医生，但是
I'm a surgeon, and I would recommend my patients to do new adjuvant therapies. Say for patients with HER2-positive breast cancer, in our domestic guidelines, it is a preferred candidate for new adjuvant therapy. So for these patients, I would use new adjuvant therapy. Concerning the specific regimen, the regular approach is TCB PH for 6 cycles of chemotherapy, with the hope that the patient will be having PCR. So in subsequent, say, prognostic, for that will be giving a better subsequent outcome.
我们时间差不多了，那最后一张幻灯片是讲的就是我希望大家能够牢记的一些要点。如果是HER2阳性3阴性乳腺癌，尤其是这些病人需要 MDT 的，那么要一开始就要给他去做 MDT。那么新辅助的话，大部分的病人我们也可以考虑，尤其是这个 TATB 的病人，我们可以不考虑。另外，我们讲到新辅助治疗，无论是3阴性还是HER2阳性乳腺癌， 会决定到底我们的术后会用什么样的具体的治疗方案，从而能够减少复发风险，把它最优化。另外，我们要做胚息检查。此外呢，虽然我们没有具体讨论了，但是我们也讲到，我们有一些肿瘤它有抑制性的，哪怕是3阴性乳腺癌或者这个HER2阳性、ER 阴性，我们也会发现手术里面有一些样本告诉你会产生一些变化，那这个变化呢，会让你考虑你在辅助治疗的过程中可以使用内分泌治疗。好，想感谢我们这一环节的所有嘉宾。好，这一环节就告一段落，谢谢大家。